You can mute everyone, only the
Chintan,
host.
please mute everyone.
I'll keep everyone on mute mode, and then speakers and chairperson can unmute.
Sure, thank you.
Yes.
My good evening to all of you. Welcome to the 78th edition. We have a stalwart speaker with us today. Next slide, please. I'm handing over the session to the chairperson of the program, Professor Dr. Tufan Pati, sir. He's from Cuttack. Sir, over to you.
Thank you, Alim. And welcome to the 78th edition of Thoughts Musings. By now, we have more than around 26,000 drop-ins in this program, and it is going and increasing. And it is all because of your kind participation and goodwill. I have to introduce, next slide please, Dr. Amrit Joshi and Dr. Alim Siddiqui. Both are eminent psychiatrists, young psychiatrists, vibrant psychiatrists of Indian Psychiatric Society. And kudos, Alim had just become the treasurer of IPS. Compliments. And with this, I shall be introducing the chairpersons. Next slide, please. This slide will keep to the end, Chintan, because we'll be introducing the chairpersons now.
Yes. My mistake, sir.
Yeah, it's okay. You do it later now. Dr. Abhay Matkar. He is professor and HOD of Department of Psychiatry in SDMC MS and Hospital, Sattur, Dharwar, Karnataka. He is an alumnus of Hubli, Karnataka University, and he did MD from FMC Pune. He worked in Army service for 12 years and then at SDMC S&H at Sattur. He won award of Dr. S.S. Jairam Articles in Mental Health by Indian Psychiatric Society, Karnataka. He got the Best Branch Award as Secretary in IMA Hubli Branch. Best IPS State Branch Award twice as Secretary IPS Karnataka. Best General Branch as IPS South General Branch Secretary. He is currently Chairman of the Election Commission, IAPP, and previously was President of IAPP Karnataka and EC member of IAPP. And also Chairman of Election Commission IAPP, co-chairman. With this, I introduce the ever-smiling, dynamic, and ever-young Dr. Abhay Matkar. Next one, please. Our dear Dr. Manoj Shahu from Raipur. He is professor and head of the Department of Psychiatry in the Pandit JNM Medical College, Raipur, Chhattisgarh. He is member of State Mental Health Authority. The state nodal officer from 2005 to 12 of National Mental Health Program in Chhattisgarh. A state mentor on COVID-19 mental health Chhattisgarh. He had been the organizing secretary of the beautifully organized Anships in 2017 at Raipur. Welcome, Dr. Manoj. And with this, I hand over the meeting to the chairpersons, Dr. Manoj Kumar Shahu and Dr. Abhay Matkar. The proceedings here onwards is yours. Please carry on.
Thank you, sir. Thank you, sir, for your kind words. And today's topic is one of the most important in clinical practice. The positive symptoms may be troublesome for the patient and their caregivers, but negative symptoms are most troublesome for the treating psychiatrist. You know, there are very few medicines, few treatment available for negative symptoms, and very troublesome in Islam. So we'll be learning more about that evidence-based management of negative symptoms. Dr. Matkar, please, for your opening remarks.
Introduction slide.
Dr. Matkar, along with the opening remarks, you also introduced our speaker, Dr. Hema Tharoor. Chintan to display the slide of Dr. Tharoor.
Okay, I know her, but this is good actually. She is quite a senior consultant at SCARF, has been working for more than 2 decades. I've been known her since her days in Karnataka also. She has been doing pioneer work in the field of schizophrenia, has a number of publications, and her work in SCARF is really exceptional. A word about an institute, SCARF per se. SCARF, of course, is Schizophrenia Research Foundation in Chennai. It's a non-governmental organization which is doing not just work in research field, but also doing a lot of work as far as patient care is concerned, and a lot of international research work goes on in this particular institute. I would like to thank IPS Orissa branch, Dr. Tofan Pati, Dr. Amrit, and Dr. Alim, and my co-chair, Dr. Manoj, for being around this. A word about this particular topic is quite surprising to state that when I started my post-graduation in late 88, we had 2 incoming molecules, aripiprazole and fluoxetine. And that's how we moved from the domain of positive symptoms or active psychotic features to something which we never knew what negative symptoms could be defined as. Frankly, we never knew it till we finished our course of 3 years. Then started emerging the so-called concept of second generation antipsychotic, and then the concept of negative symptoms. And cutting the long story short, we have moved from that era of just curtailing the symptoms, that is positive symptoms of schizophrenia, to looking into multiple domains of schizophrenia. We talk about cognitive symptoms, we talk about mood symptoms, now of course we talk about negative symptoms, and a whole lot of work has gone, and most of it is done in the Indian scenario. And I'm sure Dr. Hema will be throwing a lot of light on that. I would be singularly be very keen to listen to her talk. Over to Dr. Hema.
Ma'am, please unmute. Yeah, thank you.
Good evening, everybody. And at the outset, I wanted to thank the chairpersons for that very sweet words. And first of all, a big thank you to Dr. Tufan Pati, sir, Dr. Amrit. And I think you as the Thursday men from Orissa, you all rock. This program is really great. And I think most postgraduates are very much looking forward to this week after week. When I was, offered to speak, I thought negative symptoms has been my huge area of interest after I've sort of entered SCARF. And I thought today I will sort of present what is there in latest research in negative symptoms, and also tell you all about experiences from the SCARF and what is happening in India, and like a take-home message, what we could do with negative symptoms. Is the slide, are the slides visible?
Yes, ma'am.
Yeah. So I want to start off by saying, this is a quote from Loyola. All of us, I think, as psychiatry residents, right from our beginning years, we've heard about the 4 A's of Loyola. But I thought I'll just quote him verbatim, where I think all of us have come across persons with schizophrenia who sit with this kind of expression in his face, with an image of indifference to everything, to friends, to relatives, to vacation, to enjoyment. The capacity for work, for caring, and for themselves diminishes. They no longer have an urge to do anything, and they can spend many years in bed. I think all of us collectively in this audience have come across a lot of people like this. So over the years, having witnessed negative symptoms so much, the whole issue is how do we tackle, like I think like the chairperson alluded to this concept. And I think we are now in an era from chlorpromazine to the new kid in the block, which is cariprazine. So which is touted as a molecule for negative symptoms. So I just thought I'll summarize a little bit of, before going into what is there in the current management, talk relevant points in how negative symptoms have evolved, what we need to focus on, a few minutes on just to understand the brain, and then go into the research. So I'll make sure that we touch upon this so that you can understand how confusing and hard it is, in spite of so much of research into this. How do we manage negative symptoms? While looking at for this topic, I was interested. This word came across called atimormia. We all have heard of avolition. We have heard of anhedonia, and I thought it's so interesting that in 1929, this whole negative symptoms was described as one vital force lacking in the patient. And I think this is a apt word when we still see patients in 2022 looking at us with that lack of that force in them. And without a doubt, collectively across all studies, 60% is the data given for them having prominent clinically relevant negative symptoms. And I think we don't have proper treatment options. I'll tell you in a while, because there are so many different ways people have studied negative symptoms, and there's so much of heterogeneity in how papers have looked at what kind of treatment options are available. So right from the neuro underpinnings of understanding schizophrenia and negative symptoms especially, it is so hard. If you look at even systematic reviews, meta-analysis, all authors finally conclude that it is the best way now going forward is to break it down and catch one symptom. So if you have somebody who's come to you and you can recognize that this person has anhedonia as a symptom, then just target anhedonia. And I'll sort of explain this going forward. So for beginners here who are listening to this talk, by and large, negative symptoms have blunted affect, alogia, avolition, asociality, and anhedonia. And various symptoms have been clubbed under each of them. But what is very, very interesting is, over the years, DSM-5 especially said that it is better to club them as two main symptom domains. That there is the person has a diminished expression, which is affect and alogia, and has either avolition and apathy, and under which comes asociality, anhedonia as a group. So looking at it as two symptom domains. Parallelly, just to touch upon that, like I think Dr. Manoj was talking about how it's so hard, positive symptoms is so easy to recognize, easier to treat. But even while somebody is presenting to you with florid positive symptoms, there are a lot of studies to say that negative symptoms would have started much, much earlier. And they seem to appear even before the first psychotic episode started. And most people, SCARF, we've been running a very successful first episode psychosis program. And we tend to see a lot of patients where once the positive symptoms sort of are controlled, and when we inquire, families always talk about where we know as prodrome, or they talk a lot about the negative symptoms starting much before the positive symptoms. So this slide sort of gives you how across the lifespan of schizophrenia, let me say, there is this background music of negative symptoms occurring at any point in time. And just a mention about how much of we all know about, in fact, there's enough data to talk about the epigenetic process happening, the inter-utero hits happening. There's a lot of work from Australia looking at risk mental states. And even in those population, negative symptoms have been highlighted, and negative symptoms being linked to poor social integration. So very, very important to understand that the onset of a negative symptom could even be at pre-adolescent state before the full psychosis gets prominent. So to just club both the slides and just tell you all that always remember that, as we all know, we know about primary negative symptoms or the deficit state, which is part of the illness, and the secondary negative symptoms. DSM, of course, DSM-5, the matrices highlight saying that just treat any symptom persisting more than 6 months. Treat them. Distinction is not necessary. But I think all of us know that we need to find out, are we, dealing with secondary negative symptoms? But to understand this whole concept, always remember that right from prodrome up till the acute relapse and beyond that, we are always dealing with negative symptoms, which I think, I must confess, sometimes in a busy OPD, we're all worried about, oh, hallucinations is fine, is the person functioning? We just don't focus on the negative symptoms. So just wanted to highlight here again, this is the latest, the NIMH matrices consensus statement for negative symptoms, that you must focus on persistent negative symptoms. And remember, persistent negative symptoms is either primary or the secondary. And since they have divided into two domains of diminished expression and amotivation, most DSM-5 group says that, okay, let's focus on this, focus on the two domains and treat the person. I'm again going back to this just to highlight to you people that how much this, if you look at recent research in the last 5 years, a lot of papers which look at it from the DSM-5 concept focus on these two constructs always. There is also this whole paradigm of looking at it like this, where this is again one snapshot for young postgraduates here to look at how both the domains exist, and if you want to look at it from an individual level. Now, what is this? We have a lot of academic terminologies and versus what clinical value. So there is this whole terminology of deficit state, sometimes predominant negative symptoms, prominent negative symptoms, persistent negative symptoms. So just now I told you, if you look at papers where you're trying to understand, there is a lot of, in fact, one criticism is there's no common terminology. And depending on the authors and how they've chosen the subjects and how they've decided to sort of assess the negative symptoms, the results tend to be disproportionately varied. Now, ultimately, one take-home message clinically is identify the negative symptoms and treat them adequately. Now, how do we treat them? I'll, in later half of my presentation, I shall address that. So this is one, this is a paper from Correll in 2020, very nicely describes the terminologies. And in few minutes to just tell you all of us know primary negative symptoms is intrinsic to the illness. Secondary negative symptoms could be, as we all understand, could be adverse effects, environmental factors, could be medical comorbidities, depression. So all this needs to be looked into. But what is more and more highlighted is between predominant and prominent is a symptom that stands out in the patient for an unspecified duration. And predominant is if overall the severity of the negative symptom, clinically relevant severity of the symptoms is much higher than the positive symptoms. So there is some, these terminologies can be a little confusing, but this sort of chart helps you, the table helps you to have a clear distinction. But coming once again to the last line is to look at persistent negative symptoms or enduring negative symptoms, which is, it could be primary or secondary, that have not responded to treatment for a minimum of 6 months. My talk is going to be mainly on how do we handle this, because I think all of us uniformly look at people who have had negative symptoms, definitely, and when we inquire with the family, it's going on, and we want to do something about it. So once again, I'm going on showing you all slides like this because there's a very nice, very simple, 5 questions that you could ask your patient just to know if there is one negative symptom in them. So like we look at facial expression, we look at how they communicate, which is speech, and also look at their interpersonal relationships, and of course, look at motivation. So one big stressor that I want to do here is all of you, if you all can just remember this slide, how do you forget rating scales? If you can just sit in your clinic, you could be in an institution, you could be doing private practice. If you could spend 2 minutes asking these 5 questions, what kind of mood are you in? How do you feel today? How do you spend a typical day? What do you do for fun? And have you had any chance to meet up with people outside your family? So remember, the stress now in treating negative symptoms is to look at behavior and not so much so looking at psychopathology. And, so they want to introduce, when I mean this, when I say not so much to look into psychopathology, it's very important that otherwise you're not able to, if you're going to sit in your OP, and I don't think many of us have the time to sit and do a seance, even though mentally you're looking at the person and saying blunted effect. But it's very, very important that you ask these 5 questions. Another important distinction is this primary negative symptoms division. Just to, again, this is for young postgraduates here, that premorbidly, like I said, even before psychosis started, the negative symptoms could have started. Then during the psychotic phase, there's a non-enduring negative symptoms. And then the person can show a deterioration of the negative symptoms. So this is one way of classifying it. The DSM-5 differences I've alluded to. Just wanted to acknowledge Andreassen's classification here. This is one slide saying primary negative symptoms and the secondary negative symptoms, which I just talked about. Yes, institute, I mean, in SCARF, we have 3 centers, and many a times when you see the long stay patients, I think we can understand the whole concept. And I mean, it's still, I mean, I think there are a lot of us who have studied in institutions. And when we see people in our long stay home, this classic thing of the effects of the antipsychotics, the secondary negative symptoms is so prominent in them in the initial years. Also, it's very, very important is to, like I said, to make sure that you don't ignore how much of social deprivation they have. Is there substance use when you're looking at secondary negative symptoms? And is it secondary to the positive symptoms? Is there depression? Very, very important to always look at medication-induced side effects also. And generally remember that the primary negative symptoms we all know are not classically responding to the D2 antagonists. Now, coming quickly to prevalence, like I said, 60% of them have at least one predominant negative symptoms. Overall, even in the last year's publication, there's work from Australia looking in detail at the prevalence rates. And there's a lot of talk in men that there's higher prevalence in men. Most of them are unemployed and have reduced functioning. And I just want you all to listen to this. There's at least one negative symptom in up to 90% of people having the first psychotic episode. So when you're seeing people with the first episode of psychosis, please spend a few minutes more to inquire about the negative symptoms. And after that, nearly 35 to 70% continue to have clinically significant negative symptoms. Again, just wanted to highlight the Katie trial, which talked about predominant negative symptoms. And again, there was a lot of focus on how the antipsychotics did not make any effect on the negative symptoms. So Katie's study findings are very significant in that area. And also, like I said, overall, even this Clamor study, which is very, very, famous in looking at prevalence rates, talks about 61% of people. So just to tell you all about 60%, even who are stable outpatients, have at least, one symptom of moderate severity. That's also to keep in mind. And like I said, when you're, just to reiterate my earlier point, there could be the primary negative symptoms there, but always make sure the secondary is ruled out. And when you're ruling out the secondary negative symptoms, I just want to spend 1 minute on medical comorbidities. Many a times Parkinson's is missed, comorbid epilepsy, obesity, sleep apnea is also missed. So it's very, very important that you look at, and of course, antipsychotic induced side effects, EPS, and these are very, very important conditions to look into. So before I go into management and what is available, just remember that over years, the slide is always there for all of us to understand that we have to look at environmental factors, what anxiety the person goes into, medical illnesses, depression, substance use being a major factor, for the negative symptoms. There's also this whole thing about looking at differential diagnosis in negative symptoms, especially when somebody comes to you. And depending on the age in which you're evaluating the patient, just make sure that many a time you see people with, it's very, very important. Like I said, I highlighted Parkinson's, sometimes multiple sclerosis, or they could have dual diagnosis, depression, anxiety, OCD, and all appropriate treatments to be awarded in that state, because otherwise you will end up just dismissing, you will be missing those conditions. And so many times when we see schizophrenia with OCD, it could be primary, the obsessive slowness, a lot of compulsions. And if you don't assess them, you could again miss it for just looking at it as negative symptoms. So it's very, very important that if you look higher up in the slide, just make sure that you look at what are the symptoms? Is it affective? Is it cognitive? Is it slowing? If it is slowing, depending on, one is most common drug-induced side effects. Also, please look at independent diagnosis like Parkinson's. Cognitive, again, over years to evaluate for cognitive decline, dementia, and sometimes comorbid. When you have, is the criteria meeting for depression, schizoaffective disorders, what I wanted to highlight. Again, quick few minutes on burden, because this is where the topic is going into, how much of impaired occupational functioning, academic performance is affected, social functioning, and quality of life. And what has been highlighted over the years is to look at avolition. So if the audience remembers, I talked about atimorphia. So avolition, or that lack of vital force, is very, very important. Lack of motivation, very, very important. And over the years, studies have looked at that there is a deficit in anticipating pleasure, and there's actually reduced pleasure-seeking behavior in persons with schizophrenia. Also, even though the topic is not on cognitive deficits, just to say that it's not in isolation, because it's interrelated. The negative symptoms and neurocognitive dysfunction, some deficits in one domain affect the other deficits. So there is impaired executive function, which could play a role in avolition and memory. And negative symptoms and cognitive symptoms deficits are very closely associated. So if I put this slide to just say that there is too many cooks spoiling the broth in the brain, if I could use that word. So we all, just focus on negative. Here you have our usual culprit, serotonin, dopamine, glutamate, GABA. And now we have further studies looking at neuroinflammation, acetylcholine, glutamate hypothesis. Again, as I speak now, we have research going into looking at nicotinic receptor and the MuGlu-R2 receptor. So there's so much of work happening in this area. Parallelly with negative symptoms, there's a lot of highlight in mainly looking at the prefrontal cortex and looking at pathways that are affected, basically the frontocortical temporal and the corticostriatal pathway. Now, why I wanted to bring in this is because, see, remember we talked about the domains and we talked about anticipatory or consummatory pleasure. Now, these areas are affected. So somebody, just imagine, all of you, if you can for a minute imagine the person with negative symptoms that you've just encountered recently. So just think of this person and imagine you can understand that this person lacks anticipatory and consummatory pleasure because of a hypodopaminergic signaling issue in his PFC area. 3 networks mainly involved: the DLF, dorsolateral prefrontal cortex, orbitofrontal cortex, and anterior cingulate. So all this is, remember, the anterior cingulate to ventral striatum is for reward. So the value of reward, they don't understand. They don't understand, I mean, because it is affected, this whole dysfunction of these tracks results in anhedonia and amotivation. Imaging, right from Meinberger's work till date, volume loss is there. So if you look at what I've highlighted in blue, volume loss starts way before the appearance of negative symptoms. And a quick mention on glutamate. We all know about abnormalities in NMDA receptor dysfunction, and which plays a big role in negative symptoms and cognitive impairment in schizophrenia. Also interesting is to look at the D3 receptor, which again, your prefrontal cortex interferes with GABA activity, and this glutamate GABA balance is very, very important for decision making. And there's a lot of work now looking at reward and cognition in your D3 receptor. So if you look at a new molecule like cariprazine, which is more of D3 receptor involvement, and that's why it's been touted as a better drug for negative symptoms. Just wanted to talk about social cognition here, and there's a lot of work looking at social cognition impairments associated with the superior temporal gyri, and with focus on our classic theory of mind concept. Oxytocin is another. Again, this comes in management, so I wanted to highlight it. And oxytocin is a neuropeptide, very important for social behavior and motivation. And this disruption of the oxytocin modulated network is also contributing to social withdrawal and schizophrenia. Now, having given this huge introduction, I just wanted to go to treatment, what is available, evidence-based, and our experience from SCARF and around, and what we do as far as the Indian literature is concerned. So mainly you have to recognize negative symptoms, assess it, and then talk about management. Recognition, like I said, that slide with those 5 sentences, very, very important. You look at body language, facial expression, activities, and currently this is a very nice tool administering the NSA-4 to assess for negative symptoms. Again, like I said, make sure that you look for medication side effects, make sure you look at comorbidities, and you look at the level of impairment. The scales that all of us know about SANS, PANIS is the NSA-16. Now, this is a very condensed NSA-4. Remember, like I said, rating behavior, not psychopathology. And just as a 4-item questionnaire looking at, is the speech less, how is the emotion, how is the drive, and how is the interest. And of course, there are other scales like the Canes and the BNSs. So, but the NSA-4 is something that you could just evaluate in your clinic. Again, management, like I said, I'll be talking in detail, but always make sure that you choose the right molecule. I know it's with negative symptoms, it's anybody's guess kind of thing, but at least I'll give you all, end of the talk, something to take home to which you all can use for, in the management of negative symptoms. Always remember, it's like a team. There's a huge focus for psychosocial intervention. And since we're looking at negative symptoms, we should encourage a lot of social interaction and environmental stimulation. So I'm again and again highlighting this is the need to move beyond rating scales. Please spend a few minutes and talk to your patient regarding those 5 questions that I talked about. So coming to management, we have dopamine modulating antipsychotics, and I'm going to talk about the non-antipsychotic agents. Out of the drugs so far, we have had, so I have to first tell you all the disclaimer about KT and KT talking about no difference. Atypicals did not show any difference in the treatment of negative symptoms. But amisulpride, again, in studies have sort of reported a difference when compared to placebo. And we all know amisulpride in the doses of 100 to 300. The new baby in the block, cariprazine, is found to be a little superior to risperidone. And of course, olanzapine has also been reported to be better for treating depression and positive symptoms. Again, comparator molecule is haloperidol. So when you read these studies, you must also critically look at what is the comparator molecule before concluding that olanzapine was good. This again, just to show the cariprazine, just to highlight, because this is a molecule that we all have available now in the last 3 months. And this study looked, it was like a 6-month study to look at differences. And if you look at the chart here, you will see that the cariprazine, again, for improving negative symptoms was significantly better than risperidone. They evaluated doses 1.5, 4.5, and 6 mg. and found clear differences in the 4.5 and 6 mg doses. There is a suggestion that if we had antipsychotics which have an alpha-2 adrenoreceptor blockade, because it could increase frontocortical dopamine, it may improve negative symptoms. But as I speak now, there is no molecule. I mean, this is again from people talking about animal model researchers sort of explaining that if we had a molecule like this. I just wanted, I go into details, but this is a snapshot of antidepressants, lamotrigine, minocycline, topiramate, modafinil, all this as co-treatment. So we first looked at antipsychotics, and we're looking at drugs which are given as add-on or sometimes monotherapy when we look at studies. So this is it, antidepressants, stimulants. I remember even during my residency days, trying methylphenidate 5 to 10 milligram, keeping in mind exacerbation of psychosis. SCARF, I have, again, I would discuss with Dr. Venkat Subramaniam from NIMANS, and he would always say that if you find somebody with an elevated CRP with negative symptoms, to try a course of minocycline, again, 100 milligram BD. So I'm going to talk about these things in a minute. And the latest is also about roluperidone, which is a sigma and 5-HT2C receptor molecule. So antidepressant by and large have, again, when they looked at studies, meta-analysis, they outperform placebo, but there's no, again, when you look at a case to case, like, do you see any difference when you give an SSRI? Like fluoxetine was very commonly used, and maybe the depression got better. So that is what, or an anxiety got better. But overall, if you look at a baseline SANS score versus after, let's say, 3 months of fluoxetine, you did not see major difference. But these are, see, I just wanted to talk to you about research evidence and experience. So when they strictly looked at augmentation with antipsychotics and comparison with placebo, of course, there is they outperformed. But remember, with first generation, there was, again, a mild difference, but not with second generation. Psychostimulants, like I said, have been used. Dexamphetamine not available in India. I talked about methylphenidate. But modafinil, interestingly, has shown benefit, but not the metabolite armodafinil. Again, reasons not specified why the metabolite is not as effective. Just wanted to highlight that. Anxiolytics, again, benzodiazepine having a major role. Again, the role of GABA and looking at the frontocortical, subcortical glutamagic circuits. And one molecule that is being touted is the pregnenolone, which acts as the allosteric modulator at GABA-A receptor. So there is some work abroad on pregnenolone. Anticonvulsant, no, lamotrigine and topiramate, very inconclusive. NMDA receptor, we all know about, the NMDA receptor hypofunctioning and glutamate's role in negative symptoms. And there have been some work with glycine and D-cycloserine, which shows some promise, but no significant effect. So I want to highlight that. Biopterin is also one antagonist of glycine-1 transporter and is not showing any effect. But memantine as an add-on to risperidone has been shown to have an improvement in negative symptoms. And if you all know, again, for cognitive deficits and schizophrenia, the matrices talks about memantine's role. Minocycline I just mentioned. So just remember, if you have somebody with a raised CRP, and now of course with COVID, it's confusing, but if you have a COVID-free person and you want to try out minocycline, remember you have to give 2 weeks of 100 mg twice a day as therapy. Again, this is looking at a neuroinflammatory basis for negative symptoms and understanding if neuroinflammation has a role. Oxytocin, again, nasal spray, intranasal oxytocin seems to improve. Again, look, improvement in the superior temporal sulcus, again, contributing to negatives. These are last few years working with intranasal oxytocin that's been reported. And saying that it plays a role in, releasing the 5-HT and dopamine in amygdala and nucleus accumbens. And again, oxytocin and its role, its social motivation. This is another roluperidone phase 2b trials happening, so not yet out, can reduce emotional expression and in the emotional expression subscales. Again, notice 5-HT2A receptor without dopamine affinity. So this is one thing that's being developed. Neuromodulation, big time. I know my alma mater, Manipal, Nimans, and all there, there is this huge neuromodulation work going on. At SCARF, we use a lot of TDCS, and high frequency RTMS has been also used, 10 hertz per set, setting. And if you use it in the left DLFPC for at least 3 weeks, you can see improvement in negative symptoms. And again, this study, and I think Niman's work, there's been quite a lot of publications looking at active TDCS, which is superior, with superior response rates. So till now, whatever I've sort of talked about, I just want to think, remember antipsychotics limited, not superior to second and first, there's no difference. Antidepressants, some statistical significance when compared to placebo, but again, clinically limited. Anticonvulsant stimulants, the rest of the drugs, acetylcholine, minocycline, I talked about, brain stimulation therapies also. Antioxidants I want to highlight because we've had quite a, which I want to share with you, the SCARF work using NAC, N-acetylcysteine, as an add-on treatment. And you have a very excellent Cochrane review talking about how effective NAC has been, again, in treatment of negative and general symptoms of chronic schizophrenia. So NAC and schizophrenia, there was work reported abroad, and again, from the Pittsburgh group and from the Zeng et al. Group saying, and all these groups had looked at double-blind RCT trials with NAC. So what we try to do is, I'll just explain in a minute, but before I enter into the work done in SCARF, I just want to say that if I'm going to convey all this research evidence into clinical practice, I think the first thing is to try clozapine, don't delay. Rule of thumb is to start clozapine for negative symptoms. Sometimes you get people who are not tolerating clozapine, then amisulpride augmentation, or sometimes you give amisulpride 100 to 300 mg. Had some experience in giving ondansetron, which we published from SCARF in the Asian Journal, 16 to 24 mg of ondansetron, 5-HT3 antagonists. It was an open label study. And only thing is, very interesting was patients would go and buy ondansetron and the pharmacist would say, oh, don't take this antiemetic. I think the doctor is giving you a wrong drug. NAC, I'll just talk in a while. Our team has just completed L-carnosine study, double-blind placebo in treatment for negative symptoms in schizophrenia at SCARF. Transcranial, we are doing this, direct current stimulation at SCARF, and major word on PSR. So the SCARF study with negative symptoms, again, NAC in India is available as 500 and 600 mg. Initially, so to make the study sample very homogeneous, we took people who are stable on 300 mg amisulpride or clozapine and who are still having predominant negative symptoms. 6-month follow-up, which was published, but I have followed them all up now for 1.5 years, and definitely I must categorically say that add-on NAC had a great role to play. So for all of you, the audience listening, you must be patient with NAC. You have to give it at least minimum of 6 months, and you will definitely see a difference beyond that. Again, it was all 18 years and above, people with schizophrenia with a SANS severity score of 75, people on stable dose like I described for a minimum of 8 weeks period. So no change to their treatment as usual. Like I said, it was an open label looking at scans, NAC's efficacy. I just mentioned this, so I'm not going to waste time here. So we had 36 people, 30 consented. We augmented them with 1.2 gram of NAC, and adverse events were monitored. And overall, we took people within 10 years of illness. We didn't want people more than 10 years of illness. And if you look, the average baseline SAN score was 83, and within 6 months it had reduced. So with time, if you look at the different domains, affective flattening, alogia, abolition, anhedonia, at the end of 6 months, I'm saying there was a significant difference. Some abdominal discomfort, heartburn, flatulence were reported generally, but in our study, they did report of abdominal discomfort, because some of them it's like an oral dispersible tablet, and they would feel a little bit of abdominal bloating. So I think even Dr. Suresh Kumar in Chennai, all of you know of him. Again, for cannabis, he uses 2.4 gram. There are studies in Australia which talk about up to even 3.6 to 6,000 and all that. But I must say that from 1.2 to 2.4 is what in clinical practice we've been trying. So when I say cost effective, when you overall look at spending for other stuff, other medications, we're going to try all the other buffet that I sort of suggested with you're trying antidepressant, you try other drugs. Instead, if you can just augment with NAC, it would be really useful. L-carnosine I've just completed in 2021, December. L-carnosine was on 2 flexi dosing, 400 and 800. There's been no difference in between the drug or the placebo. Attention, cognitive, we have seen a difference at 6 months. The manuscript is submitted, it's under review, so I'm not talking about it in great detail, but I want to tell you all that we found differences in cognition, especially in the attention. Like I talked about ondansetron scarf work that we did, but there's been a lot of noise on the gut and brain, and looking at probiotics and the role of vitamin D and probiotics for 12 weeks. Again, targeting negative symptoms. Just wanted to highlight the latest curcumin and negative symptoms, pro-cognitive effects. So there is something called the soft gel nano curcumin, which is given in 16 weeks for stable people, and they saw an improvement in schizophrenia. I just thought, since we are all thinking of so much of China with COVID, this is the Chinese medicine for negative symptoms. It looks like a biryani recipe. I know I'm talking late into the night, but this is what the Chinese do for schizophrenia, for negative symptoms and positive symptoms. So I just thought that it would be interesting if we actually seriously had today's a wrong day to say Indo-China work, but in a COVID background. But yeah, this is what is given in China. There's a lot of role in cannabis and negative symptoms. In fact, this study, when I was looking at it, CBD cigarettes instead of normal cigarettes as an innovative treatment for schizophrenia. Study is ongoing, not completed, touted to complete by July of 2022. It'll be very interesting if to look at this work, how there's a lot of this cannabis use disorder in schizophrenia, and whether cannabis helping with depression, and depending on all of us know that depending on if there is excessive use, how much it can affect motivation. But there is also this lot of work looking at CBD oil for negative symptoms in schizophrenia, and this role of CBD cigarettes. So just wanted to highlight this about CBD oil for schizophrenia. Right from 2012, it has started with ending in CBD cigarettes for negative symptoms. I talked about neuromodulation, so just wanted to highlight that more work is coming in neuromodulation area. This is very, very interesting. Just wanted to highlight this. It's GPS mobility as a digital biomarker for negative symptoms. This is a group in Israel. They've looked at schizophrenia persons with smartphones, looked at their GPS-based mobility indicators. And this is again, ecologically movement statistical analysis. I must confess it was beyond, I want to read the paper to understand, to even explain that, but just to say that this is the kind of work that they're trying to look at. So People with less GPS mobility had greater negative symptom severity and greater GPS mobility with weakly associated with poor community functioning. So I thought I must highlight, since we are all in this area of digital mental health. Mobile health or M-health, smartphone apps for schizophrenia, trying to look at digital phenotype, big data to personalize digital psychiatry. This is a personalized real-time intervention for motivational enhancement. It's the mobile app that's been developed, and our own, I think we should proudly, hopefully it will roll out end of this year or early next year. The AIMS and IIT Delhi group are bringing about 2 apps. One is Disha for schizophrenia and Saksham for chronic illness. So just to tell you, mobile app, and again, apps targeting for the families also, so that their queries can be answered. Psychosocial intervention, big, very, very important, since like I remember my initial 5 questions: lifestyle, social skills training. So there's this Opus program in Denmark, which in first episode, psychosis, which talked about only doing the social skills training, CBT. They were very much focused on the psychosocial rehab in people with schizophrenia in the first episode. And again, with lifestyle, looking at alcohol, smoking, social participation, and family education. This is another SCARF work with NIMANS, looking at add-on yoga, which I wanted to highlight here, because as part of psychosocial rehab, and they had initially 89 participants and then got to 64. And add-on yoga group showed a lot of improvement. Again, the role of oxytocin coming in with yoga as helping with the social cognition, that yoga, neuroplasticity, and we all know Professor Gangadhar's work in this area. So there's been this role of looking at yoga for negative symptoms. Exercise, again, just want to highlight exercise. And I would like the audience, it's when we see all these papers, when we see individually, when we see people in clinic and tell them go and join, go for a walk, and you see the person with negative symptom look at you and wonder, what are you trying to say? So, but there's a lot of evidence to talk about exercise, encouraging people for exercise, which will improve their negative symptom functioning. This is another motivational enhanced training, home-based manual called MOVE, which targets emotional processing, pleasure. It's a skill-based approach. SCARF had an opportunity. Frances Dark is in Melbourne. She had come to SCARF to train people with her. She has a specific manual for social training in social cognition and again in interpersonal therapy. And this is to quote her, like 20 weeks of individual therapy. Patient reported anxiety. Somebody with negative symptoms said he's anxious. And she said, the fact that he could express, he could feel an emotion, that should be your target, that he's able to verbalize that. Cognitive remediation, like we all know, a lot of work in that area also, improving neurocognition, social cognition, and helps in the frontocortical structures. And they all seem to have a small to moderate beneficial effect on negative symptoms. CBT, again, the target is to improve, again, so the traditional CBT may not sort of, you're looking at somebody with negative symptoms where you want to highlight their motivational enhancement in them. So you can target like at that individual's, either it could be his self-esteem, it could be his anxiety, it could be, so that is what is being talked about in, CBT in psychosis. But overall, pooled together, the effect size was about a 0.4. So summary of the treatment options, like I said, I talked about antipsychotics and non-psychotic agents having a like efficacy in terms of amisulpride, cariprazine, and overall the antipsychotics having mild or moderate effects. So remember, partial D2, D3. So the amisulpride, cariprazine group is much more better, and always looking at beyond dopamine would be better. And rather than looking at the entire negative symptoms in totality, breaking it down. I'm going on highlighting, break down the symptom and address. To conclude, it's very interrelated, positive, cognitive. Between all this lies the negative symptoms. neuromodulation showing a lot of promise, and I think we should also look in that area. Psychosocial intervention is very, very key. And I would, tell the audience to please think beyond dopamine. So I just wanted to end with these last two slides. I started with Bloiler, and this is Professor Castle in Australia saying that we need to treat positive symptoms. It's very difficult to do functional rehabilitation with severe positive symptoms, but the residual negative symptoms, just don't be satisfied with them. Make sure you're assessing them, you're treating many of them. They may be secondary, or it may be like I talked about the primary negative symptoms, but it's very, very important. Please keep pushing the psychosocial rehab. I very, very thankful to the group. We lost this great stalwart a month ago. I'm starting this year from SCARF, and I thought this talk should be dedicated to her. She would always say, her words was, forget all this, just give them some love. So I wanted to end this talk with the group. My big ode to her, salute to her. She has seen chlorpromazine to cariprazine, and she always talked about giving love to patients. And I think she was a driving force in starting PSR and SCARF. So thank you very, very much for this opportunity. Sir.
Thank you so much. Thank you so much for a wonderful presentation, ma'am. And we will remember this portion of love also. Over to chairpersons for their opening remarks, sir. Then we can stop the screen sharing now.
Yeah.
Thank you, ma'am, for the excellent presentation. When we were doing the postgraduate, only option left at that time was either to reduce the antipsychotic or go for psychosocial intervention. See, after 20 years, still psychosocial intervention remains the main area, main focus to treat the negative symptoms. We have seen so many drugs, but ultimately it's still the psychosocial intervention which is very helpful in treating the negative symptoms. Dr. Marcus, please. Now we can open the session for questions, comments, and queries.
Salim.
Yeah, thank you. I think Dr. Philip John is here. I think he wants to make a comment.
Unmute कर लो.
Sir, you have to unmute yourself. Yes, sir.
Sure.
I only. Okay. Can you hear me now?
Yes, sir.
Okay. I just wanted to mention about Dr. Hema's presentation. It is marvelous. I learned such a lot today. And look at the number of people who have attended, almost 400. I just wanted to mention, Hema, about moving on from when you talk about neurobiology. We are talking about genetics, epigenetics, neurobiology, and then we actually seem to keep on struggling with the dopamines or the other neurotransmitters that are involved. I think it might be useful when you talk about negative symptoms, which are so pervasive and sometimes very ubiquitous. When we talk about the salience dysregulation, I think it's important to talk about a concept of the balance between the negative and the positive in terms of symptoms, as well as the negative GABA and the positive excitatory neurotransmitter glutamate. I think ultimately our answer might lie there. So when we have to actually keep moving on from here, research in the next 10 years, I'm sure, will be defined by this, when I may not be around. But that's a grace that I think neuropharmacology will have in treating these symptoms is what I feel. Thank you very much for the presentation.
Matkar, sir.
Yeah, I'm sorry, I was not unmuted. I was not allowed to speak. Okay.
Please make
Ma'am,
him
excellent.
co-host. Rohit, please make Dr. Matkar as co-host.
Yeah. Now I'm on. Okay. Thanks, Dr. Hema. You've given an exceptional talk. There'll be a lot of questions. I'm sure you'll run short of time. I had only one question on this particular issue. Could you look into the issue of use of ECT for negative symptoms? Has there been any role or study?
Sir, there's been some in like review of ECTs, again, primarily not for negative symptoms, but overall when they've looked at improvement. So the discussion was whether depression improved or, with ECT.
Okay.
Depression being a confounding variable there. But rule of thumb, negative symptoms, ECT will worsen cognitive deficits. All that argument is there. So if you ask me clinically, will I give ECTs when we are, again, we have the other neuromodulatory techniques, I would go for that rather than give ECTs.
Okay. Fine. Thank you.
Ma'am, there is a question. Any role of very low dose first generation antipsychotics?
No, sir. I mean, if we are left with, they don't make any difference. I'm rooting for NAC, sir. We should do one multi-center study with NAC in India.
We are ready. We are ready, madam, with our centers. Dr. Shobhit, you have some question to ask. You have raised your hands.
Ma'am, first of all, thank you for such a successful presentation, ma'am. And it was a learning curve for all of us. Just few comments. Actually, the people who want to now probably want to carry on the research in negative symptoms, ma'am, I just reviewed this negative symptoms and has actually submitted a chapter. The problem with is the definitional issues here, because then primary enduring negative symptoms, whether we are talking about that, whether we are talking about secondary negative symptoms, now prominent negative symptoms have come up, predominant negative symptoms have come up. So a whole lot of gamut of how much positive symptoms are included in that negative symptomatology. This has become a persistent and consistent lacuna in research. That is why probably we are getting inconsistent results. Initially, we get very enthusiastic findings in some studies because of these definitional issues. Later on, when they are refined, the results wane off. So maybe this consistently can be taken up in the future. Regarding TMS, we in CIP stimulated cerebellum, and cerebellum has a very prominent connection with the anterior cingulate cortex. And we found in schizophrenia there were encouraging benefits, short-term benefits in negative symptoms. Subsequently, I was talking to people in AIMS. They were taking it up further in a large and more longer follow-up trial. So maybe those results could be interesting. Thank you, ma'am. These are two my comments.
Thank you, Shobhit. Ma'am, there's a question in the chat box. You have already spoken about the role of stimulant, but I would like to ask you, how frequently do you use methylphenidate or a R-modafinil or a modafinil where do you put these stimulants when you look at negative symptoms and the treatment of negative symptoms?
So when I have attentional deficits predominantly, Amrit, so you have somebody who's, again, functioning, like it could be from the job perspective or studying, then I've used a lot of modafinil in practice. Methylphenidate, again, you must be very, very careful not to prevent relapse of psychosis, so around 5 to 10 milligrams.
Thank you.
Ma'am, there is a question. Someone has shared a problem that my mother is going through a relapse for last 4 years. She is taking risperidone forte, glonanserin, and carbamazepine. She has relational deficit and lacks motivation at times. As a family, we are doing as much we can do to support her. What other things must I do, especially to help her building the social skills?
Oh, this is like a MD exam. No. So to start off, it'd be nice to know the age of your mother and maybe to review the medications she's on, one. And I think if you get, I'm very willing, I can ask my staff. We've got a very good hand now with a very efficient person who can handle from occupational therapy perspective, looking at one-to-one, first to assess when you say social cognition, somebody who can, interact with her and find out. One is the expectations of the family and her expectations. So when you say building social skills for somebody who's 55, you must first assess what was her pre-morbid nature and really what do you mean by social skills. So this is, Pragya, I'm very much willing to talk to you one-on-one. I think this is too much for a meeting to discuss this whole thing. Yeah.
Now, madam, I want to ask you about the role of cannabis now.
Yeah.
So I think that opens a Pandora's box. Now we talk to patients that your cannabis is actually precipitating the illness or prolonging the illness. So what are we going to take? Negative symptoms or positive symptoms? Now we are giving cannabis to an individual with negative symptoms. We are pushing him on to some positive symptoms. So what would you choose between the two?
Again, very interesting work. So see, this is again CBD oil at, they're also saying CBD tablets. So for the audience, this is not your regular marijuana tetrahydrocannabinol. We're looking at, it's cannabidol. So that, again, at 600 mg and 800 mg. Okay, all proof of concept studies helping in negative symptoms. I've had colleagues of mine who are using CBD oil in autism. Okay, and again, if I can digress a little and say, and we look at autism's social interaction, and they actually are using CBD oil off-label. So there has been work in giving CBD oil or CBD capsules. Once see the CBD cigarette. In fact, if you go and look at the paper, FDA said, kindly do not start prescribing this to your patients until the study is out. So it's, I think, interesting in the next 2-3 years when this comes out.
Thank you, madam.
Hello, Dr.
I think Dr. V. Sai Kumar wants a brief comment.
Yes, sir. Thank you, sir. Thank you for the opportunity. It's a great presentation. I really enjoyed it. Ma'am, can you please tell us a little more about the relevance of CBT during the primary and secondary symptoms of secondary negative symptoms?
You're talking about cognitive behavior therapy?
Yes.
So, see, CBT, again, you must make it very individualized. You must know what to target. So I'm just going to connect with that earlier question somebody had asked about her mother. So let's say she is extremely anxious and you want to deal with anxiety in her. Then remember, CBT in psychosis is about, you don't touch the delusions, you don't. So since you said negative symptoms, you first find out, so it could be even behavior activation. So what I talked about, that motivational enhancement, helping, putting up a behavior activation program which has exercise or yoga depending on your center. And so many of them are very amenable depending on if they are able to do the thought diary to deal with anxiety. So we routinely engage in CBT and SCARF depending on education, how psychologically minded they are, and target on. So when you say, which primary or which secondary, that's why I said forget the definition, focus, break down the symptom, pick a symptom you want to target in CBT.
Thank you, ma'am. Ma'am, there is a question regarding the importance and role of expressed emotions.
Yeah, that
in our domain, this domain.
Yeah. Express emotions in general, I mean.
In negative symptoms. What is the role and how?
Now, over time, even though I think as a student, we used to be taught and we had to know Camberwell family interview and expressed emotions. But now I think in family education, see, one big part of PSR is family education. And I think to bring in Professor Sharda Menon's words, so you can address to the family about hostility, warmth, and those concepts of EE, and help them in when you psychoeducate them about the illness.
Yeah. There's another interesting question, madam, and it has always been my doubt. So as a PG student, I'll ask you as a teacher, maybe. how to differentiate between amotivation syndrome of cannabis. Now we are talking about cannabis that's versus negative symptoms of schizophrenia. How to isolate
Motivation,
them?
now the theory is thrown out with cannabis. That's my answer. No. The initial concept of amotivation, and really does amotivation exist? There is an over. So that is why I didn't put it up, because then it will become very controversial. So the aim is the CBD cigarette and CBD oil treatment to target. So in amotivation, they've divided it into what I talked about, anticipatory pleasure, and how they can, there is a deficit in reward pathway that the person with schizophrenia has an issue with understanding getting the reward. Same thing with the cannabis person. So they're trying to see people who are high cannabis users and schizophrenia and compare doses of CBD capsules in them. So there is a great overlap in the symptom presentation.
Okay. And ma'am, regarding the symptom presentation, there is a question. How do we differentiate between a young adult who is having ASD, Asperger kind of disorder, and another one with schizophrenia with predominantly negative symptoms?
I think with an Asperger and maybe if you said Asperger versus schizotypal, that would be hard, because many a times you have the birth history, developmental history, and the schizotypal. You sort of feel they're very interchangeable, but by and large, if a high functioning Asperger versus schizophrenia itself, in terms of clinically, when you see somebody, one is the history, and where, unless you're saying hebephrenic schizophrenia at 16. So clear-cut history, developmental history, the sensory deficits that you see in somebody with Asperger, obsessive symptoms very early, which are missed, and comparison with somebody with schizophrenia with, when you say only negative symptoms, I think it's again, MD fail questioning, you know.
Dr. Abir sir has asked an interesting question. You were talking about, so for the touted effective molecules like NAC, oxytocin, minocycline, ondansetron, does it really separate from cognitive symptoms, or is the improvement in both domains?
So again, negative symptoms only. We didn't assess for cognition, but the ones that we have followed up for 1.5 years now, when we have looked at, I mean, again, not as part of the study, when there has been definite improvement in attention and memory and these areas.
Ma'am, there is a mention regarding Brahmi, Bacopa, Ashwagandha with Hania. Any help from these agents?
You're like converting me into the Maharishi up north. When you say Brahmi, Ashwagandha, no, I don't think there's no role for Brahmi for sure. I think Professor Andrade has done a review on that and said no difference. But no, I don't. I've actually asked. So when patients, so I'm talking about clinical relevance. Patients tell me, can I take Brahmi? So I don't say no. I think it's a good placebo. But yeah, have I seen?
Madam, another
Dr.
question.
Murli, there is Murli.
Yeah.
You can ask him to give his input because he works a lot with the. Dr. Murli, you are here?
Sir, please unmute yourself.
Because in most of your centers, I have also seen a number of chronic schizophrenics with predominantly negative symptoms. I have gone around them a lot. And how do you manage? What to take on this?
I can't hear your audio, sir.
You unmute Dr. Murli.
Sir is unmuted, but his audio.
Can you hear me now?
Yes, sir. Yes, sir.
Yeah. At the outset, I would like to say that it was a very good presentation by Dr. Hema. I think she has covered all the recent advances in the negative symptom treatment. But I really don't know why we should really go behind this to find a complete solution for total symptom improvement. If you look at the recovery model, I would like to go for that, because even with a lot of symptoms, patients can function adequately, and a lot of issues to be left to the patients themselves, how they can take control of situation, how they can do it. And in the chat box, I also saw that some people asking for tobacco in various forms. This I have seen it in various setups where we say that this person is not motivated to do anything, but at the same time, you find that they observe, keenly watch the people who are going around on the road by smoking, and when they drop the cigarette butt or BD butt, they immediately go and take this. Now, whether this has got any this thing to say that there's some amount of reward which is given. Similarly, there was a period when I was in the rehab center at Nimans, the initial phases, they used to give BDs as incentive for patients to work. And at one point just stopped completely. And subsequently what used to happen is that all the attenders and IAs, they used to make the patients do good work, but not the clinical psychologist who used to give the token economy and various rewards. So there is something much more powerful reinforcer, which is helping these people to seek for something. That is some. Let me stop at this place. Then rest I have seen is that social skills training with a direct first-hand experience with Robert Paul Lieberman in his own area in California. What happened is that after all the social skills training of the veterans group of people who had a large chronic psychotic illness, and at the end of the day, you find them still be on the road begging for BDs and cigarettes. So this is something very difficult to understand and difficult to explain. And I hope that as Hema has told, that there are a lot of new innovations, either physical method treatment as well as psychosocial rehabilitation, which are all being tried. And if you really look at it, there is nothing which can be recommended as a treatment for negative symptoms, as per the most of the meta-analytic reviews. Now, psychosocial rehabilitation has been considered to be very, very important. And that is where I have to have full agreement with Dr. Hema on what Dr. Sharada Menon Madam has been talking about. Give love and affection and recognize the individual as a person rather than a patient. I think I would like to stop at this.
Thank you, sir. Ma'am, there are comments regarding two things. Regarding cariprazine, what is your take on that? What is the future of the molecule? And there is a question in the chat box on long-acting risperidone and paliperidone. How are they helping in negative symptoms? Please, ma'am.
So the data I shared about cariprazine is their study on negative symptoms, and it's just 3 months old now. I think 3 to 4 months old in India, and I think maybe so at SCARF and in the other places, few of us have started the molecule. We are seeing, so this would be more of experiences from people who especially in again a motivation and a volition, we are seeing some changes in persons who are, so I've had actually patients telling me, I like this molecule, meaning after you've started this drug, I'm feeling something. So like how I mentioned about patients expressing their emotions. So cariprazine definitely showing promise, but I must also acknowledge here two things. I had one person reporting of a temporomandibular joint dislocation after taking cariprazine. And then when I asked her, she said she had been prescribed aripiprazole in the past. So just to tell you all again, the same D2, D3 receptor, and this is also being a D3 receptor at a higher, whether both molecules cause this. So I had one experience like this, and one quite few patients reporting of severe constipation. I'm just saying that the molecule is just 3 to 4 months old. There have been a few people reporting of, pooled effects of us consultants in SCARF and outside are saying that it's a good and it's weight neutral. So there's a lot of patients saying that they're not gaining weight and all that. Overall feeling better, but I think too early to comment on it. The other, sorry, sir, the other question.
Long-acting risperidone and paliperidone.
Again, long-acting paliperidone, there has been, if you look at paliperidone literature, they talk about in first episode psychosis, improvement overall there in negative symptoms. But overall, there's no difference between first generation long-acting and second generation in improving negative symptoms.
Okay, ma'am, the proper dose of amisulpride, what should be the dose range
100
usual?
to 300 mg for negative symptoms.
Okay. Amrit, have we covered all the questions? You're on mute. Unmute yourself.
I think we should give Madam a rest and maybe call her again. Let us not exhaust our resources so fast. I think she's spoken long enough and on a lot of topics. I think we need to give a break. We'll go.
So Tufan Pati sir and then the chairperson sir. Chairperson sir.
Yeah, Dr. Manoj, I'm extremely thankful to Dr. Hema for covering this topic so extensively. And I must admit, I was the first one to benefit so much from what you spoke today. I'm sure we can translate it into better patient care in the days to come. Thank you, Dr. Hema, and thanks everybody for giving us this opportunity to chair. And Manoj, your remarks finally?
Hopefully, I'll start using NAC for negative symptoms as Matt suggested, and we'll have the clinical experience. Hopefully, this will definitely help patients with negative symptoms, as the report already of whatever studies she presented. So hopefully, in future, maybe NAC will be one of the most useful medications for negative symptoms. Thank you.
Tufan sir, please. Sir, unmute.
I'm thankful to all the participants, a large number of participants in this Thursday musing. And I really admire a lot the extensive but lucid presentation and explanation by Dr. Thurur, and about a disease with negative symptoms, which is always a challenge to treat, at least quite disheartening, discouraging, because patients with negative symptoms, they pose a problem for their family members and they come with many issues. But there is a hope, and this hope has been shown by Dr. Hema Thurur. So we will ask her to enthuse more hope in the coming sessions. And I do hope that we'll invite you and you will keep our request. Thank you, Dr. Thurur.
Thank you, sir.
So to end this, thank you, Hema madam. It was extensive, it was brilliant, and it was, we had a packed house. It was a blockbuster series today. So the organizers are all smiling from year to year. So we would want to have you another time. Thank you so much, madam. And it was about the study you want to have in other centers. We have a lot of people who want to do some research, and if it comes from the top organization like SCARF, the whole methodology, everything will be robust, and I think we are all ready to join. If you really feel
we'll
that,
definitely join that.
We want to
do it.
Thank you so much, madam. Abhay Matkar sir, the most handsome man in today's show, always smiling.
No. Thank you. I was really
I am giving the final comment, sir. You are not allowed to speak now, sir. You are the most handsome guy today, and you have to accept it. So, no discussion on that. So, thank you for telling it, for giving a brilliant overview of this subject. Manoj bhai, thank you for coming today, enlightening us with your wisdom, knowledge, and your insightful inputs. Thank you, Tufan sir. Thank you, Alim. Thank you to the entire audience. We had more than 450 participants today. It's a huge one. Thank you, Torrent, for